and South Africa has technically entered the third wave. This as the national 7-day moving average incident of 5,959 cases now exceeds the new wave threshold as defined by the Ministerial Advisory Committee. The Advisory Committee defined the new wave, a 7-day moving average threshold, as 30% of the peak incidence of the previous wave. To break this down for us, I'm now joined by Professor Salim Abdool Karim, who is the director at the Center for the AIDS Program of Research in South Africa and also professor of global health at Columbia University in the United States. Previously was, of course, heading up some of the operations here in South Africa in our fight against COVID-19. WhatsApp your questions immediately right now on 072-110-5584 or tweet us at Newzroom Afrika channel 405. We'll get those to the Prof. Professor, good evening and thank you very much for joining us tonight.
Very good evening, Thabo, and very good evening to all the viewers.
Of course, it's a technicality, but we are sitting at a 7-day moving average of incidents now at 5,995. That threshold, I think, was at 5,600 if we were looking at 30% of incidents that happened in the previous wave. So would you say we are technically in a third wave nationally, or is it still those 4 provinces that were previously mentioned, that is Gauteng, the Northern Cape, the Western Cape, and the Free State?
Yes, when we look at the approach that was adopted, it was to give us just some way in which to create a categorization to determine whether we're in a wave or not. And so those cutoffs were developed by the modeling consortium and adopted by the Ministerial Advisory Committee. They are, to some extent, arbitrary. We have, in effect, been in a third wave in this country for the last 3 to 3.5 weeks. So it's not, I mean, today is just we passed some number, but in effect we've been in a third wave for quite a while. Because when you think about the cases, and you think about there were 9,000 odd cases today, you have to look at that as those cases today, the infections actually occurred somewhere around 10, 14 days ago. So somewhere, usually between a week and 2 weeks earlier is when those infections took place. So let's, for practical purposes, say that it was 10 days ago. So that means that 10 days ago, these 9,000 infections occurred. Today, those are not 9,000 infections occurring. Today, they're going to be a lot more. So because we're now at a doubling time, that will be somewhere in the region of 2 weeks, 2.5 weeks, we can expect that today there were probably closer to around 15,000 odd infections that occurred. And those would then be the ones that, you know, will feature in 2 weeks' time or 10 days' time. So we have to think about it that the cases we're seeing are reflecting infections occurring quite a while back. So we've got to intervene early in order to stop or slow the spread of the virus.
We're saying late April, early May that we are not vaccinating and therefore a third wave is inevitable. Well, a third wave is inevitable and a third wave is here. We are still not vaccinating at the rate that we should be. Our vaccination is limping. Of course, we are waiting for the FDA to give us a go-ahead on the Johnson & Johnson vaccine. There is vaccine apartheid that is limiting access to vaccines. What does this mean? What is the implication of hitting a third wave with a limping vaccination campaign? Mind you that most South Africans are concerned because they are looking at that apocalyptic situation in India when they hit that third wave.
Yes, Thabo. So let's just deal with the issue of the wave in India, because that's a slightly different situation to what we're dealing with. With regard to India, they were in a situation where they had a new variant and they had several super spreading events, including religious festivals, political meetings, and so on. So those created a situation where the virus was seeded very rapidly into the community and a new variant spread quite fast. And they were very quickly overwhelmed, and so they started running out of oxygen and so on. We are not in any of that situation right now. To start with, we have very detailed plans to ensure that we have adequate oxygen. That's something that was put in place right from the first wave. And when you think about the first wave, in preparation for the first wave, Deloitte, together with Right to Care and the Department of Health, brought the 4 big manufacturers of oxygen together, put detailed plans in place to ensure that we will not run out of oxygen. So those plans are already in place. We are much better prepared. Now the problem comes about, or let me address the second part of your question, which is, so what impact is vaccination coverage going to have on this third wave? Put very simply, there are very few countries where vaccination is going to avert a third wave, or any wave. To do that, you would have to reach very high levels of vaccine coverage. So to get to a point where you would prevent a third wave is very difficult. I would say we're probably looking at 2 or 3, 4 countries at most. What we instead are trying to do is to vaccinate those who are most at risk. So when the wave hits us, that we reduce the number of people who require hospitalization, who get severe COVID. And that's the goal. So it's about individual benefit, principally for healthcare workers and the elderly. So our goal is slightly different. We can't avert a third wave using vaccines at this time.
And that's exactly where many are saying we are failing, Prof, at protecting the vulnerable. And I don't know what the feeling is on your part that we have gotten to a point where those who do get severely ill are unprotected at this particular point. In fact, we are losing most of them, with the death numbers now sitting at over 57,000.
Yeah, and that's been one of the big challenges we've had to deal with in this pandemic, that we have 2 kinds of deaths occurring. The first are those that we know about and who are officially reported as COVID-19 deaths. Now, when you look at the death rates we should be expecting, you base it on the age distribution in our population. And so technically, when we calculate it in terms of our population age distribution, then we should have a substantially higher number of deaths. And that's reflected in the unreported deaths. So we count those as what is called excess deaths. The trouble is with the excess deaths, we don't know which ones are due to COVID. And so we can't really assess what fraction of those, but it's quite likely that quite a large number of those excess deaths are due to COVID. Now, why do people die of COVID? The underlying issue revolves around comorbidities and relies on age. Those are the 2 biggest factors. And unfortunately, in our country, even though we don't have a large elderly population, we have a very large population of people who have diabetes and hypertension and HIV and tuberculosis. And so those comorbidities are driving our death rates. Now, we need to get to vaccinating all of those individuals. That's going to take quite a while. That was not something that could be achieved, in a very short space of time. Now, overall, if we can vaccinate our entire phase 1 and phase 2 populations, so that covers individuals with comorbidities, the elderly, and so on, and that we are aiming to try and achieve by the end of the year, that translates into close to 40 million people, then we will make a big impact. That's the kind of impact you want to see, which is, there's only a handful of people in hospitals. Right now, we need to be thinking about how is it that we can slow transmission. Yeah. We did it. We've done it before. Right. Look at the second wave.
The NICD is saying we need to act, and we need to act now to do exactly that, limit the transmission. What is your view? Do we need to get tighter measures in place, or is what is in place currently adequate?
I think the measures we have in place right now are simply too little. If we want to really slow the transmission of the virus, we've got to be taking much more substantial steps. Now, let me explain why I'm saying that. When we're dealing with the spread of the virus, people have to come out of their complacency. They have to come out of, let me give you an example. In January, when we were in the midst of the second wave, when I take my morning walk, everybody wears a mask, without fail. I mean, if I see somebody without a mask, it's unusual. These days, when I walk in the morning, I've got to stop and talk to and tell easily about 1 out of 5 people to put on a mask. So what we've got to do is we've got to alert people, and they've got to understand the seriousness of this coming wave. And they don't see it right now because it's only occurring in Gauteng and the smaller provinces. When it starts growing in all our coastal provinces, then this virus will really take off. And that's when the numbers will rise, and then suddenly people get scared and they start wearing their masks. We've got to get them to wear their masks now. And to do that, we've got to send a signal. And that signal must be, we've got to take this much, much more seriously. The second thing we've got to do is we've got to act much more strongly on gatherings. We cannot be having, in the current situation, gatherings of 100 people. What happens is when you have a gathering of 100 people, the risk of a positive person, let's say you have a gathering of 100 in Johannesburg, the risk of a positive person is pretty high. And any little break in the procedures, you could infect 100 people. It would be in the community. Before you know it, it's growing out of control.
Director at CAPRISA and Professor of Global Health at the Columbia University in the United States, Professor Salim Abdool Karim stays with us. I want to talk to him a little bit more. What does a third wave look like? We couldn't predict exactly when it will hit, but do we know what it will look like? With us tonight here on In Focus, the Director at CAPRISA and Professor of Global Health at Columbia University in the United States, Professor Salim Abdool Karim, previously chairing, of course, the advisory on COVID-19 here in the country. He says, well, we technically had entered a third wave even maybe 10 days ago, really. If you look at the numbers, we are just technically saying it's happening today. But the question, Prof, is we couldn't tell when exactly the third wave would hit, but how will it look? All right, will it be worse, more severe than the second one?
Oh, that's a difficult question to answer. It's very difficult to predict because there are too many unknowns in the equation. On the face of it, at this point, the virus that is spreading is the same virus that spread in the second wave. And that's the 501YV2 virus that is now called the beta variant by the World Health Organization. So it's the same virus. Should that change, and there's a possibility it could change at any point, in other words, at any point we could get a new variant. When that happens, if we get a new variant, then the situation will be very different. Then we would have no way of predicting what this new wave is going to look like. If the current variant remains, then we are likely to see a third wave that is probably similar to our second wave. But that again is dependent on how seriously people change their behavior.
Maybe we have forgotten, sorry, Prof, let me come in there. Maybe we have forgotten what that second wave looked like. Just a recap for us in terms of the numbers and the intensity of how that wave hit us.
So when you think about the second wave, we were expecting something similar to our first wave, which is that it started very slowly. We started seeing cases increase at a slow pace in the Western Cape, and then it spread to the Eastern Cape. The second wave hit us because this new variant spreads about 50% faster, what happened was that it very quickly spread within the community. The line that goes up went up very sharply, and within a matter of 2-3 weeks, the hospitals were full. Now, we are starting to see that now in Gauteng, that it's in that same phase. The line for the third wave in Gauteng is very similar to the line in the second wave. Yeah. If that trend continues, we'll see something similar at the other provinces.
Now, you've mentioned Gauteng, I think, 2 or 3 times already, and I saw a reaction earlier on that NICD announcement that we're technically now in a third wave. One person there said, well, Gauteng is driving the third wave, or driving the nation into a third wave. Is that true?
Yes, I think that's a reasonable way of putting it. Essentially, because the bulk of the new infections are occurring in Gauteng, that many of the individuals there have infection but don't know it. And they are either asymptomatic or pre-symptomatic. And they are traveling because they're quite well. And so when they travel and come to KwaZulu-Natal or go to the Western Cape, that's the way in which the virus will then get seeded into the other provinces. And it's very hard to control that because these individuals, they don't feel ill, even though they are infected. Yeah.
So, I mean, that would mean as far as containment measures are concerned, we might need to once again go back and look at provincial limitations or moving around into provinces?
Yeah, so we tried that. And it is very difficult to limit provincial travel. And the main reason it's difficult to limit, it's because fundamentally our economy is dependent on the large amount of traffic we have, for example, between Johannesburg and Durban, between Richards Bay and Johannesburg. And so if you try to cut that off, it has a huge impact on the economy and will make things very difficult in other ways. And in many ways, we don't really have borders that we can really control. You know, we can just put some policemen there, but we don't really have strict borders in that sense. So interprovincial travel is very difficult. And last time we tried it, it didn't really achieve its goal as much as we thought it would. In that it's just too porous, there's still too many people traveling.
Let's look at some WhatsApp messages then coming through today. This one from Mbulelo saying, Professor Salim should have been appointed interim minister, finish and clear, competency, professionalism, and no cadre deployment. I suppose the real question there, Prof, is around leadership. Should the nation be worried around the instability in leadership in the Department of Health and a fairly inexperienced minister coming into that position at a time of a pandemic?
We have seen across the world how important leadership is in dealing with COVID. In fact, in dealing with any crisis, leadership is a critical part of it. We saw how leadership that prevaricates and doesn't make decisions or downplays a problem or denies the problem, the impact that has had in the United States under the Trump administration. We have seen how, in Brazil, the virus still spreads quite rampantly because of just poor leadership from President Bolsonaro. So on the other hand, we've seen how countries have done well with good leadership, as we've seen in New Zealand with the way in which they have been able to contain the virus because of the strong leadership and decision making. So there's no question across the world, leadership is really important. And we've been fortunate in this country to have had the leadership of the president and the minister. The minister himself has played quite a key role in terms of the leadership on the ground. He's been very supportive, actively involved, going to provinces, going to hospitals, and that's important. You want a leader who's visible, who's actively involved, who's knowledgeable, and who instills confidence. Fortunately, I think, we have a new minister. New minister will hopefully learn very quickly and come up to take up this challenge. But a lot of the decision making and a lot of the leadership decisions that need to be made are very institutionalized now. And they're institutionalized because they are committees and they are individuals in the Department of Health, in various committees that now drive this. The minister plays more of a public role, whereas behind the scenes, a lot of the ways in which things work are now much more firmed up. So I'm not concerned that it will have much of an impact. I think where it would have an impact is the visibility part of it, and that's going to be quite important for the new minister to play that and to step in and to take up that challenge together with the deputy minister.
Papi Namanda Sir is asking the question, is the vaccine rollout still on a trial phase?
So the vaccine rollout in South Africa has been in two parts. The first part was called Phase 1. And Phase 1 focused on healthcare workers, and that was principally through what is called a Phase 3B study. It's a research study. But the way in which it's done, there's no control group, there's no placebos or anything. It's in effect an early rollout program. And so that involved the first 500,000 or so doses. And when the Phase 1 was coming towards its end, we switched to the rollout itself, now taken over by the government. That's no longer a Phase 3 study, but it's really no research, it's just implementation. And that has now involved just over 1 million individuals, and that's two groups. The remaining healthcare workers are continuing to get vaccinated under that program, but the focus is now heavily on the elderly, people who are over 60. So anyone over 60 can literally walk in and get vaccinated at this time. Our problem is that we need to be vaccinating our elderly, our above 60-year-olds, at a much more rapid rate than we are now.
Yeah.
The number of vaccinations we are giving each day is below the number that we had set as our own target.
Right.
The problem now is not that we can't do it, because we can, is we don't have the doses. Yeah. That's where the problem comes about.
Is there a way around the struggling to acquire doses?
That's a big challenge. And the reason that it's a big challenge, and that's not a challenge unique to us, it's a challenge across the world, is that the biggest suppliers of vaccines aren't able to keep up with the supply. So the agreements that we have in place is for companies to provide us with a certain number of doses at a certain rate. The problem is that in any one of these factories, something goes wrong, or there's some issue that needs to be resolved. They are backed up, and now they're starting to deliver, a week, 2 weeks late. And so we can't help that. Nobody's deliberately trying to not give us vaccines. This is about systems in place in our suppliers that hold us up. And now, our two big suppliers are Pfizer and Johnson & Johnson. We depend on Johnson & Johnson because that's a study we know that it was done in South Africa. It works against our variant, the beta variant that we have. And so that's the vaccine we want to use. We didn't anticipate that the company making it will have a problem, and now we can't get the vaccines until it's released. So we have many challenges in getting enough vaccines, and we're not alone. We're one of many. We've got to, just keep trying to do better.
There have been some views, Prof, that we shouldn't tie ourselves up with Johnson & Johnson or any other specific vaccine, actually, but we should look at getting a cocktail of vaccines being distributed in South Africa. What's your view on that?
Absolutely correct. In fact, in the original vaccine strategy, we called for at least 3 different classes of vaccines. Well, we said 2 to 3 different classes of vaccines to be used. You do not want to vaccinate your entire population just with one vaccine, because let's say there's a problem with that vaccine that emerges, a year later or 2, that, the immunity is short-lived. and another vaccine is actually doing better. So you want to have a mixture of different types of vaccines. And for us, that means at this stage using two completely different kinds of vaccines. There are two different. One is mRNA, the other one is a live viral vector. And so that's why we've gone with Pfizer and with J&J. They're two different classes. Ideally, we should use a third class as well, or use a different vector, and that's something that has to be expanded into. The issue comes about is we have to depend on our regulator. Our regulator must make that decision. We cannot go around second-guessing our regulator. We have to have some confidence and trust that they are making decisions in our best interest. If they tell us that the evidence is not strong enough, then we have to accept the evidence is not strong enough. We have to trust their judgment because we're trusting them to protect us, that they don't give us a vaccine that turns out later it doesn't work against our variant, or that it's not safe, or we don't know whether it's efficacious.
Professor Salim Abdool Karim, I appreciate your time and thank you for joining us on In Focus tonight. As a director at CAPRISA and professor of global health at Columbia University in the U.S. Professor Salim Abdool Karim.